Welcome to this explainer. Look, if you are a med student and you've ever felt like you're literally drowning in data on the wards, trust me, you are absolutely not alone. Today, as a senior medical educator, I'm going to walk you through the actual science of how we learn. More importantly, we're going to figure out how to structure that learning so you can build genuine clinical competence safely, effectively, and without burning out. Here is our roadmap for today. We'll start by hitting the medical learning curve, then break down Bloom's revised taxonomy. After that, we'll climb the cognitive ladder step by step, align our learning outcomes with assessments, and wrap the whole thing up by tackling how to manage your cognitive load.
All right, let's dive into part 1, the medical learning curve.
So why does learning medicine feel so incredibly overwhelming? I mean, you step onto the ward and you're instantly bombarded with just a massive wall of complex clinical data. Every single patient is a unique puzzle, every rotation introduces completely new protocols, and the pace, it basically never slows down. It feels overwhelming because, well, objectively, it is. But this actually brings us to a crucial educational theory that completely validates your experience and explains exactly why you feel this way.
Enter cognitive load theory, developed by John Sweller back in the 1980s. Sweller proved a simple but honestly profound concept. Our working memory has a strictly limited capacity. It's kind of like trying to pour a gallon of water into a tiny teacup. If instruction overloads it, learning is directly impaired. If we throw you into complex clinical tasks before you've got the foundational steps firmly in place, your working memory overloads and your learning completely halts. You literally cannot process the information.
Which brings us to part 2, Bloom's revised taxonomy.
To keep that teacup from overflowing, we rely on a hierarchical framework to safely build up your clinical competence. Now, the original framework was developed by Benjamin Bloom way back in 1956. Its core assumption was brilliant. Higher-order thinking absolutely requires a lower-order foundation. Fast forward to 2001, and educational psychologist Lauren Anderson, who, fun fact, was actually a former student of Bloom, and David Krathwohl updated this classic framework specifically for contemporary education.
And here is the really critical shift they made. They swapped out passive nouns for active verbs. Knowledge became remember. Comprehension became understand. This is absolutely perfect for a hands-on, active profession like medicine. They also move the ability to create up to the absolute peak of the hierarchy, placing it right above evaluate. This 2001 revision is the gold standard used in medical education today because it intensely focuses on what a clinician can actually do.
So let's get into part 3, climbing the cognitive ladder.
Let's see how this actually plays out on the wards using a high-stakes clinical scenario, neutropenic sepsis. This is where theory meets practice, guys. You cannot safely evaluate a patient if you haven't first grasped the basic pathophysiology. You've got to climb these 6 levels sequentially. Skipping a step? That is exactly what leads to cognitive overload and dangerous clinical errors. Let's walk through each rung of this ladder.
At the lowest rung, level 1, we have remember. Here, you're simply recalling or recognizing previously learned factual info. The active verbs we're looking at are things like list, name, recall, identify, and define. In practice, if you're operating at this level, you can recite the textbook definition of neutropenic sepsis perfectly. You can rattle off the risk factors from memory like a pro. But, and here's the catch, while you can name those risk factors, you can't actually explain why they exist or how to treat them. You just have the disparate puzzle pieces sitting on the table. Stepping up to level 2, we hit understand. Now we're moving well past rote memorization. You start finding clinical meaning in your own words. The verbs shift to explain, describe, summarize, classify, and compare.
So at this level, you can actually explain exactly why a low neutrophil count inherently skyrockets a patient's risk for a severe infection. You are finally connecting the hard science to the disease process. You aren't just reciting facts anymore, you possess true comprehension of the why.
Now the crucial pivot is taking that understanding into brand new clinical situations, which brings us to levels 3 and 4, apply and analyze. Applying means taking your knowledge and executing a plan in a new scenario. Analyzing is taking that clinical data, breaking it down into its component parts, and examining how those pieces actually relate to each other.
When you bring this to the ward, things get super dynamic. First, you apply a management algorithm you learned in a textbook to a brand new, unseen case of neutropenic sepsis. Then, you step up and analyze. Picture this, you're looking at 2 different patients who both have a fever and low neutrophil counts. You have to distinguish which one is more immediately concerning. Now you're actively executing algorithms and making critical real-time distinctions between actual human beings.
Finally, we reach the very top of the taxonomy: evaluate and create. This is the pinnacle of your training. You transition into making advanced clinical judgments based on distinct criteria and eventually producing entirely novel solutions.
Here is what that looks like in our clinical scenario. For evaluate, you might review a management plan for a neutropenic patient, justify what's appropriate, and critique exactly where it falls short. And for create, you might literally design a brand new neutropenic sepsis treatment pathway for your specific hospital ward. Now, obviously, we absolutely do not expect you to design a hospital pathway on day one, but this is the ultimate destination of your clinical scaffolding. It is the highest form of mastery.
Moving on to Part 4, aligning outcomes with assessments.
Understanding this taxonomy isn't just for your own studying. It's absolutely vital if you're a junior educator designing teaching sessions for your peers. Before you teach, you have to identify exactly which level of thinking you're targeting. If your learning outcome is set at level 1, say just recalling risk factors, but you assess the student with a level 5 task, like critiquing a complex treatment plan, oh man, you've created a damaging mismatch. A session targeting basic recall must never be assessed with an advanced evaluation task. It completely shatters the learner's confidence and fails to accurately measure what was actually taught.
And finally, Part 5, managing your cognitive load.
Bringing this entire explainer back to your own well-being, let's look at why honoring these levels is honestly your primary defense against burnout. As we learned from John Sweller, pitching learning outcomes above a student's current cognitive level creates the exact conditions for cognitive overload. If we expect you to evaluate a patient before you can even remember the pathology, your limited working memory is instantly overloaded and learning just stops dead in its tracks. You cannot build on a foundation you haven't yet established. Picking the right level in Bloom's taxonomy isn't just some academic exercise. It directly dictates whether you actually learn or whether you just burn out trying.
So, I want to leave you with this question to ponder as we wrap up today. Where do you currently sit on the cognitive ladder for your clinical rotation? Are you still at remember, or have you pushed up to apply? And more importantly, what specific active verb is your very next step? I highly encourage you to honestly assess your own position on this framework today so you can safely and efficiently climb to that next rung tomorrow. Thanks so much for joining me in this explainer, and I will see you on the wards.